Bismillah Rahman Rahim. Good afternoon, everyone. Uh, we are starting our CBEC forum today. And to all those who have been, who are not familiar with our format or this forum we do every other month or every second month. It is a forum that has very different types of topics, national and international, ranging from art and literature and history to politics and social sciences and also medical sciences. So, to give you an idea, our previous forum was on the future of bioethics with a professor from Kenya, Dr. Bukusi. And before that, we had a forum with a lawyer from India, Dr. Saif Mahmood, and he introduced us to Urdu poetry and the history of Indian capital, Delhi. So we have very different types of topics, very diverse range of topics in our forums. So today we are going to see some ethical debates around dilemmas in addressing medical care of pediatric population and especially the nephrology patients. So this forum will be led by Dr. Ali Lanewala. He is a pediatric nephrologist working at SIUT, and he also has a master's degree in bioethics. And with his expertise in pediatric nephrology and ethics, he will be joined by his colleagues from India and Washington, USA. Uh, Dr. Ali will be introducing our other two speakers in a while. So, without further ado, Dr. Ali.
Thank you very much, Farid, for this kind introduction. This ethics forum, we've been discussing a lot. It's been a while we have discussed these clinical ethics related issues. So this time we wanted to do something with the clinical issues, and then this came to mind that we were this group of ours, me, Priya, and Aaron, and we have Dr. Cecil Levi from South Africa also in our group, that we were jointly working on an invited paper in which we were trying to make a framework to approach ethical issues in clinical medicine. And so this group, we are, as pediatric nephrologists, we are already endangered species, rare species in the world. There are very few pediatric nephrologists. And we are also rare because the three of us share this interest in ethics and we have some extra training in it. So we thought that we will share our views of when we see the patients in our clinics, our perspectives are different. Our approaches to these problems are different. And when we were discussing these issues amongst ourselves, how to approach them, we discovered this, that all four of us belong to different parts of the world, and all of them have different socioeconomic background. So our approach towards these problems are also very different. We have only 90 minutes, and in that we will try to give you different dilemmas. All three of us will present a case, and this case will be followed by how you would see from your context these even as a dilemma, and if it is a dilemma, then how would you approach them? Okay. So the first case will be presented by Associate Professor Dr. Aaron Wightman. He is a pediatric nephrologist at University of Washington School of Medicine, Seattle. And he's also a faculty at the Truman CAD Center for Pediatric Bioethics. So, Aaron, over to you.
Thanks, Dr. Lanewala, and thanks again for the opportunity to participate and learn today. I wonder, oh, there we go. Could you give me a thumbs up if this is the appropriate view of the slides? Great. Okay. Let me get oriented on my screen. Again, I'm Aaron Wightman. I'm a pediatric nephrologist and also bioethicist working in Seattle, Washington, in the U.S. I'm going to speak about one of the cases that we spent some time talking through. I don't have any financial disclosures. I should say that this case is based predominantly on one, but really on three real cases. I do have permission from the patients who are involved and their parents to use their cases for teaching purposes and for scholarship. I've written about this case, or the main patient in this case, in another article that's publicly available, if anyone has interest in taking a look. But here's our case. So this was one of my patients. She was 17. She had a neurogenic bladder, so was not able to void on her own, and chronic kidney disease. This had been managed quite successfully with clean intermittent catheterization from a young age. And since about the age of 12, this patient had been performing self-catheterization independently. And in a lot of ways, she was a model patient of mine. She was delightful. She was successful at school and elsewhere. She was adherent with the catheterization and with the medications necessary to treat her kidney disease. However, since the age of 15, so really the last 18 or so months, she's had 4 admissions for pyelonephritis and acute kidney injury. And with each episode of pyelonephritis, so kidney infection, her serum creatinine levels have risen and her kind of underlying kidney disease has progressed. So she's moved now to chronic kidney disease stage 4. So stage 5 would be when sorry, I should know my audience. Dialysis and transplant. The patient is, on questioning, admits to non-adherence with catheterization. So that's the reason for her infections. She doesn't want to catheterize anymore. She also doesn't want a vesicostomy, which would be a surgical procedure that could prevent the need for catheterization. She doesn't want dialysis. She doesn't want a kidney transplant. She does want to live. She's evaluated by her school social worker locally and by our psychiatrists in Seattle, and both agree that she's not clearly depressed or suicidal. Dr. Lotto, I want to mention that we spoke a bit about context in all of our cases, and I want to share a bit of mine. I'm fortunate to live and work in Seattle, Washington, which has a history both in dialysis and in bioethics. On the top of the screen is Belding Scribner with his first chronic dialysis patient, Clyde Shields, and the Scribner Quinton shunt, which he developed, which was the first chronic dialysis access, allowing for long-term hemodialysis. And on the bottom are unblacked out the members of the Admissions and Policies Committee at the Seattle Artificial Kidney Center, also known as the Seattle God Squad, the lay community or the lay committee that selected the first patients to receive chronic dialysis. I work at Seattle Children's Hospital predominantly, which is a highly resourced hospital with large uncompensated care resources, and similar to your institute, with a very large catchment area. So we are the Children's Hospital responsible for 5 states in the United States, Alaska, Idaho, Wyoming, Montana, and Washington State. That accounts for about 30% of the geographical area within the United States. For our patients who live in Washington State, Medicaid, which is a state insurance, is available for children of families with limited resources, though it's not available for their parents to help pay for medical expenses. And in the United States, for citizens who have kidney failure, Medicare entitlement is a federal insurance that is available, which covers the costs of dialysis treatment, kidney transplant, and immune suppressive medications. And additionally, I should say in terms of context, I'm fortunate that children in the US have priority for kidney transplants. The average time on the wait list for a deceased donor transplant for a patient at my center is a little over a year these days. But as I said, I work in Seattle. I live in Seattle. My patient did not, and in fact, the clinic where I saw this patient was not. This patient was seen in a clinic in Pasco, Washington, which is a beautiful, much smaller community, 3.5 hours away from Seattle in the heart of Washington agricultural country. So this is where the cherries, peaches and grapes, the produce that Washington used to be known for before Microsoft, is grown. It is a community with much more limited means. Most of my patients are tied to the agriculture. And this patient lived with her mother and 3 siblings, actually an hour away from that clinic, and an hour further from Seattle. There were no local mental health resources where she lived. Her high school had a social worker who was willing to do an evaluation once, as I mentioned, did not feel the patient was suicidal or depressed, but who also felt she was too medically complex to continue to see her. This patient's mother was invested in her daughter's well-being and had tried to convince her to resume self-catheterizing for over a year, but ultimately kind of took a step back and said that it's up to her to decide whether she's going to catheterize or not. I can't make her. And there were increased number of medical encounters with this non-adherence. So this meant more trips to Seattle to see specialists who I would send them to. So trips to see psychiatry, trips to see the adolescent medicine specialist, to see a palliative care specialist, and then trips to see me in the outreach clinic. And while insurance paid for the cost of the medical visit, it didn't cover the expenses of travel or the expenses of missed work. And this was financially taxing upon the family. Ultimately, a lot of repeated efforts were made to partner with the patient and identify alternatives, identify additional supports, and identify modifiable barriers to support resuming clean intermittent catheterization. But these were unsuccessful. So when I think of conflicting moral values in this case, one of them is a conflict or a tension between the emerging autonomy of an adolescent versus our duties, our efforts, our desire to protect her from harm, or on the flip side, to promote her benefit. Raising questions like, should the adolescent's refusal to self-catheterize be respected? What's in her best interest? There's pretty clear consensus among us and her parents, or her mother, I should say, that it's in her best interest to catheterize, but she refuses. Yet her desire for continued life is discordant with this action. Does her refusal violate the harm principle, where I practice perhaps justifying state intervention to provide consent or compel therapy? Her refusal does place her at severe, preventable, and imminent risks of serious harms. So we have a number of discussion points that I'll mention quickly and then stop talking. Is the physician or the state or parents or all of the above responsible for ensuring compliance with recommended treatments? What are the merits or demerits of compelling treatment in these scenarios? Pragmatically, can such treatments be compelled? The most important question for me is how should the physician respond to continued non-adherence with catheterization? And how do physicians approach these problems with more limited resources? Pause here.
Thank you so much, Aaron. It's really it's open for the forum now. The forum is open for discussion amongst the participants. So, what do you all think about about this case where a patient who is not willing for the treatment, can you force that treatment to them or anybody else? Like our online participants can also participate in this discussion.
Young people here who are involved, who are our trainees, who are involved in not exactly the same, but you can face this issue. So, Dr. Ali, it would be interesting if would one of you like to say something?
Also, I would like to just add another twist to this very, very interesting case. This is a 17-year-old. Would we be thinking differently if she was slightly older, 18? Yeah, maybe she's 17 years and 11 months right now. What if she was 18? Would we still be posing the same questions?
So,
Aaron, you want to answer for that? What if this would have been an adult? I mean, it's had crossed that limit of adolescence.
I'll say that for myself as a pediatrician who often continues to follow patients after they reach the age of majority, which in where we are or where I'm practicing is 18 years. All of these questions are still the same. The legal environment is somewhat different. Once a patient reaches an age of majority, once they turn 18, we shift from an assumption of developing capacity and competence to an assumption of capacity or competence. And so an informed refusal we take much more seriously. And kind of pragmatically, or not pragmatically actually, but in terms of ethics, as we think about that as I think about it for my patients, if we focus on principles, our primary principle shifts from pediatrics, which focuses predominantly on beneficence, to a focus of placing greater emphasis on autonomy, at least in the US, which would lead us to treat this somewhat differently.
So
But I think the same questions would be present.
So, Dr. Wightman, I'm Dr. Moazem. This is a really interesting case. You started off by calling this young lady somebody who was the best possible patient, and obviously something has shifted for somebody who did everything to this. You did mention that there was psychiatry, psychological, social input in the sense that she was referred to people. I'm by training, I'm a pediatric surgeon, so I understand a little bit. I can empathize with the issue. So I'm just curious, that was what could they, surely they would have come up with some reasons why this patient had kind of shifted dramatically from full compliance to non-compliance. Do you have any more information about that area?
Yes, I do. And forgive me for being slightly unprofessional for a moment. Dr. Moazem, I know exactly who you are and very much admire your work and appreciate it. The closest we ever came to finding the answer for this specific patient was that her mother entered into a newer relationship and had another child. This infant child became kind of the focus of attention in the family, whereas as before, this patient had been somewhat the focus. That her remarkable success in spite of her chronic disease had been a focus, and that had shifted within the family, and that had shifted, and that was one change that coincided with this, and the other one was unfortunately high school. that it was different to go to high school and have to do clean intermittent catheterization. And the patient was open that she didn't want to do it at school. She didn't want to do it at home either, but definitely didn't want to engage in catheterization in any type of social environment or to feel different in any type of social environment.
Okay, that was helpful. Thank you.
Luke has a point.
Yeah, Dr. Valerie Lukes, can you turn your video on and ask or
Yes.
add your comment? Thank you.
Thank you very much. I mean, I think this is absolutely fascinating and this is beautiful. I'm actually an adult physician, and I have to say we deal with this all the time. You know, even people who don't stop smoking when they have heart disease and all sorts of things. So my kind of feeling here is, you know, as pediatricians, in a way, you almost have a luxury that the parents kind of force adherence to a certain point. I think in this particular case, obviously, you know, besides like pinning this child down and catheterizing her, which would be enormously traumatic, I think there's almost nothing one can do apart from what you did, or you know, trying to obviously figure out why and was there something you could change. I think just thinking about this over the longer term, if this child deteriorated because of this non-adherence, this might be something also for Dr. Levy, for example, from Johannesburg. Would this history impact your choice to actually transplant this child if she got worse? You know, so would she be someone who got stuck on dialysis because of this? And I think that also to me is sort of a, you know, something that one has to think of down the line, obviously, if the child deteriorates. The other question is it just the catheterization that she's not doing, or is she also not taking her medication? Thank you very much.
Okay. Can we take the other point, the same point a little further in this discussion? And you see, in our part of the world, we do not have those kind of social services and support system. So for us, if we try to tell them the merits and demerits of following the treatment protocol, and if they don't, then it's up to them. You know, we just leave them alone and we say, okay, we have tried to explain to you and you're not following our recommended treatment. Now you will be responsible for whatever bad consequences you'll face. So for us, looking at these kind of problems as even problems in our clinical practice is something that we all need to learn in a way that, you know, these can be really challenging dilemmas for a physician and these whole families. So if anyone else would have any different experience, Dr. Mal?
Yeah, I think we should go back to Dr. Valerie's question, but just one comment. Dr. Ali, that's not what I would do as a pediatric surgeon. That is up to you. You can do what you want to. I would be a lot more assertive. Dr. Valerie's question, maybe we can return to that.
The transplant, yes.
Dr. Aaron has responded it in the chat box, but can you please expand on Dr. Aaron?
Yes, yeah, happy to. So to kind of work backwards through the comments. Our central issue related to adherence was catheterization. The patient did appear to take her medications that I prescribed. She did appear to take the supplements that I prescribed for her as well. But it was the catheterization. The transplant question did come up, and we did discuss both in terms of discussing what appeared to be the inevitability of developing kidney failure with continued non-adherence with catheterization, and then concerns about whether a transplant would be helpful in the case of continued non-adherence with catheterization. And I'll ask the surgeon who's participating to forgive me, but at least as a nephrologist, the urine has to go somewhere, whether it's from a transplanted kidney or from one's original kidneys. So in some ways, a kidney transplant wasn't going to solve her issue. And so we had conversations about that as well.
Thank you. So we have a comment from Dr. Beziai Abib, and she or he, I don't know. I'm writing from Ethiopia, and it's quite interesting to see that we all face the same clinical issues, and that it's difficult to see these patients deteriorate, especially in our setting where chronic pediatric RRT is unavailable. We also have another comment from Sadaf Asim. In my opinion, she is in transition of care and approaching adolescence. We need to discuss and have an evaluation and the reason for her changed attitude.
Okay, so these two are comments. It's good to hear the same the comment from Ethiopia. So, Doctor, how would you approach such an adolescent in Ethiopia who is not adherent to your prescribed treatment?
So as the author said, there's no actual social workers here. We counsel the parents on the need and the progression, if not, towards advanced CKD. And we insist. Sometimes we tell them to have continuous drainage at least overnight if they're not willing to do CIC at all. So at least we will have some overnight drainage. But we don't really have any leverage or any social workers to help with the counseling. And so if they come on board, that's good. Otherwise, we try to manage them medically, and that's the end of it.
Okay.
It would be interesting to know what Dr. Mozam said, that she wouldn't do what Dr. Ali was suggesting. What else could be? How would you approach it, Dr. Mozam?
Well, that'll take us away from the main thing, but I would look for other ways, and I think Dr. Aaron has explained very clearly what is going on in this child's life. And it goes beyond her. And the other thing is the expense. So I would perhaps do a little bit more soft paternalism, stuff like that, but then that'll take us into another area. I think we should come back to this case.
Salia, want to
And also, I think what Dr. Wightman talked about in terms of what was happening in her life situation, because that's before you mentioned. I mean, this is really the cusp of adolescence, where I feel that young women are also realizing their sexuality and everything. And I feel that this could potentially have, and this was just this was just something that at the back of my mind that was happening out, perhaps within the context of the United States. And then I was thinking, okay, what would be happening to a woman who's perhaps 17 years old in Pakistan and who has some of these issues, and what would be the socio-cultural and religious issues that would come into play? And I think they would be completely different. And I think for me, those would also be like as a thought experiment, what would be happening? What socioeconomic status is she belonging to? Because the way that the treatment is approached would also be entirely different depending upon the socioeconomic status of the person, what class that this particular 17-year-old belongs to, and what are her other social circumstances. So I just want...
Sorry. Just to add to that, the contextual thing that Ms. Saleha has raised, within Pakistan, this particular situation would not be just the mother and a 17-year-old. There would be a larger number of people involved, giving you a few more options.
And also the issues with neurogenic bladder. I'm not a physician, but I feel that this particular thing of purity that is associated with Islam, I think those are some of the concerns that perhaps would be raised. And this is particularly if he's someone in the age of marriage, for example, what are some of the ramifications of that for that particular person? So for the family, I think these would also be central concerns at that point in time. So the family would perhaps be playing a greater role. in how it unfolds in Pakistan.
So we have two more comments from Dr. Valerie before we move on to the next one. And Dr. Valerie, if you can always turn on your mic and add your comment and all other things. She says that, should I read your comment or can you?
I can just quickly, sorry, I don't want to ask too many questions, but I was just thinking, just wondering how to get around this. The one question is, did she have a metrophenol or was she actually catheterizing via the urethra, which might be, also two different options that that are a little bit different. And then the other issue is whether, for example, one could go to the class and explain to take some of the stigma away, because it seems that maybe catheterizing at school was probably a big problem, more than at home in the privacy.
Thank you.
Yeah, this was through catheterization through the urethra. Metrophenol was an option that was also discussed that the patient refused. And she, the possibility of discussing this at school was brought up, which the patient was not in favor of because she felt that it would create further stigma for her, and which the patient's mother was also not particularly in favor of. I just want to name briefly, because I think two kind of sort of brief things is, one of the challenges is, all of us know, having been adolescents at one point at the least, or working with them, is, the assertions of independence during the time of developing autonomy is developmentally appropriate. We're supposed to do that. The trouble is that in this case, the patient's assertion of independence was to refuse to do a treatment that she needed to do to maintain her health. And I'll add that I have a lot of resources that I'm very fortunate to have that other places don't. I do have psychologists I can involve. There's a social worker in the school. And I have a state social service system that I can appeal to in cases where I'm concerned that there is medical neglect or refusal of a treatment that I recommend that places a child at significant risk for serious, imminent, preventable harms. But this was a case where those resources didn't really seem to help much. The patient wasn't depressed. She didn't meet a definition of clinical depression or suicidality. When I called the state about this patient, they told me that they asked me, they declined to intervene and said they wouldn't because she was 16 at the time, but then that she was going to be 17. And ultimately it was the adolescent who was refusing to do it and taking her out of her mother's custody. The rest of the family was in Mexico, wasn't going to change the adolescent's refusal, or at least they didn't think.
Okay.
I wonder, for the sake of time, if I could just say a little bit more about the third point before we move on, or do we have time for that?
Okay, we can have a minute.
Okay. Well, I really appreciate this discussion and the opportunity to learn from all of your expertise. This was a very challenging case for me. And it was a challenging case because thinking about this third question of how should I respond, what in these situations, good care for this patient, I don't think could be found in respecting her burgeoning autonomy, because respecting those choices, as we said, would result in further progression of her disease or death. It also, I don't think, is really understood through beneficence, because I met with this patient a lot. I cared a lot about her, and she continued to not catheterize, and her disease continued to progress. So I think good care, but perhaps supererogatory care, was really found through trying to preserve or promote the relationship between myself and the urologist, I should say, and this patient. even when we know the patient was likely to remain non-adherent, resulting in significant morbidity or mortality, that continuing to meet with her, continuing to advocate and be present manifests a caring and therapeutic relationship. And the development of that relationship and efforts not to abandon it, the act of continuing to care for and about our patients, even what for me was a particularly distressing case where the outcome is likely to be poor, had value for the patient and me in and of itself. And without that relationship, as one-sided as it felt at times, I think our practice as pediatricians would feel unfinished and deficient. And I should say to Dr. Loix's point that she put in the chat, over time, at least, we did start to have meaningful conversations about dialysis and what that might look like. And eventually the patient did transition to dialysis, although eventually was able to have a vesicostomy placed and years later move towards kidney transplant. But thank you all again for the opportunity to participate today.
All right. So I know that all these cases are such that we can go on with these discussions, but we have to move this on because we have two more cases. So our
Can I just make one comment? Dr. Aaron, very brief comment. It's not in the final analysis, and that's the point you're making. Very often, particularly in our part of the world, it's not psychologists and sociologists, but it is the individual physician who, and all of them can't, but those who do have that relationship with the patient, and although it's long drawn, I think that is what is needed, something that medicine is losing. So I think within the circumstances, what you did is perhaps was the best way out. Thank you.
All right, thank you very much. So our second case will be presented by no other Dr. Priya Pais. She is professor and head of Department of Pediatric Nephrology at St. John's Hospital, Bangalore, India, and she will present a case about a child in the middle income country. So Priya, over to you.
Thank you, Professor Ali. I'm just, the screen looks different for me to share than I did before.
You are a co-host, Dr. Priya.
Okay. I'm sorry, my desktop is actually not showing. It's
Share your presentation from my system.
yeah, I think you could do that because this is not showing yet.
Okay, just a minute.
Even though I was able to share it half an hour ago. So,
Can you see?
hello everyone. Yes, I can. Thank you.
Mhm.
I'll just say next slide or move on. So, thank you, Professor Ali, for inviting me to participate in this. I think this is my first time joining you all, but I think have interacted with a couple of you before. And it's very nice also to be in the company of Professor Moazam, whose book I have also read. So a little bit of context, I grew up and did my medical training in Bangalore in South India. And then I moved to the United States and did my training in pediatrics and pediatric nephrology, and then worked there for several years before moving back to my alma mater to continue to work. And so seeing the difference in outcomes of my patients, despite having, an excellent working in a tertiary care center, an excellent level of expertise, is really what spurred my interest in ethics. And so that's really what started my journey. So I'm going to talk about the ethical challenges of inequitable access to dialysis. Next slide. So I think you'll have to hit the return button for the points to appear one by one. So my setting here is a tertiary care pediatric nephrology center in a low middle income setting. And this case is really to demonstrate how children with kidney failure can access care, either in a country like South Africa, where sometimes treatment is rationed, or in a country like India, which has two different healthcare settings, and perhaps also in Pakistan as well, in the public sector as well as in the private sector. So the patient is an 8-year-old girl who was treated 5 years previously for steroid-resistant nephrotic syndrome, but then she was lost to follow-up subsequently. She presented suddenly with all symptoms of kidney failure and now requires the initiation of maintenance dialysis. Between 3 years and 8 years, her kidney disease had progressed, so she thought the family did not seek treatment. So she lives with her father and younger sister in a village 100 kilometers from the center. The child's mother had died 3 years ago. The father is a daily wage laborer, and the family is quite poor. I think they're using the previous version of the slides, but that's fine. So the father would like to provide dialysis for his daughter. However, with his work, he is unable to do manual PD for 12 hours, and it seems like hemodialysis is the only option. Next slide. So now if we look at two different contexts, we have peritoneal dialysis that is available to the child equally distant, around 100 kilometers away, distant from the family. The first setting is a public sector hospital. In this setting, the government pays for dialysis, but there's limited funding and there are limited dialysis beds and a waiting list of patients. So in this setting, it's the nephrologist who is responsible for selecting the most suitable candidates to take those limited dialysis slots. So the nephrologist would most likely refer to criteria, and the criteria usually include those that will select patients that have the best outcomes or patients who are dialysis candidates. Now, with their distance from the unit and the lack of family support, there's really, other than the father, no one to bring the child for dialysis. The child does not meet criteria to get a dialysis slot, and the nephrologist must turn her away despite her medical need. Next slide. The second setting is a private sector hospital in which the patient and the family has to pay for dialysis. So over here, there's no shortage of dialysis slots, but each session of hemodialysis costs the father 2 days' wages. So the father, as I'm sure we are all familiar with, in that difficult setting, is unable to make a decision and asks the nephrologist what they would advise. So if hemodialysis is initiated, the father will have to pay not just for the dialysis, but also the travel and lose his wages when he misses work to take the child for dialysis, resulting in catastrophic healthcare expenditure for the family. As we have frequently see, the family will have to take loans to meet all these expenses, and they will be driven into poverty, and the patients and the siblings' education will also suffer. Next slide. So the ethical challenges from the perspective of the public sector hospital has to do really with the principle of justice. It seems an injustice the child is denied a life-saving treatment based on socioeconomic criteria that are beyond her control. From the nephrologist's perspective, it is also an injustice because the nephrologist has to play God and ration a treatment that is limited from no fault of their own, but due to the scarcity that the government is unable to rectify. Next slide. The sort of conflicting moral dilemmas from the context of a private sector hospital is that from the family's perspective, the burden falls on the father, the burden of decision making. This child's survival is determined by his ability to pay. Should he focus all the resources of the family on this child, or should he actually refuse dialysis if he knew what would be the cost to the family in the long term? From the nephrologist's perspective, we all, as pediatricians, advise treatment in the best interest of the child. But is it beneficent to only consider the interests of the child, or do we, as physicians treating a child, also take into account the interests of the family? And would it harm the interests of the family unit to advise dialysis to this family who clearly, it seems, is going to be unable to afford it? Next slide. Okay, so there was one more slide there, I think, in the latest version that I sent, but essentially, it raises ethical problems for all three stakeholders in this decision making. The child, is going to have poor outcomes, either in the public sector or in the private sector in this particular circumstance. The caregiver is going to suffer a lot because of the terrible decision-making burden that is on them, and also because of even if he does undertake dialysis, the expense that his father is going to have to bear. And not to forget the nephrologist, who is going to have moral distress, either in the public sector because they have to select the patient, deny some, accept others, and even in the private sector where I work, to see a family refuse treatment because of financial reasons, which will ultimately going to lead to the death of the child. So that's my cases from two perspectives. Thank you.
Again, it's open for discussion. Anyone has any points? How would you approach? There are two perspectives here. One is from the physician's perspective, that now you have to refuse treatment, or you have to, in the interest of the resources, you have to select the best ones and say no to the others. So that burden of that moral distress. So how do you deal with that?
What would you do in this case?
Okay, so
sorry, I just said, Dr. Ali, what would you do in this case? This is a very familiar thing for us to face.
And interestingly, the place where we work is that the treatment is all free. Dialysis here, the father does not have to does not have to pay the hospital for the dialysis treatment, but the hidden costs that are associated with this kind of treatment. If the family lives 100 kilometers from here, it will be a huge burden to bring the whole family or half of that family to this big city. And where would then they live? What will be what work would they do? What would happen to the other children of the family who are otherwise healthy? And while living here, they will need all those expenses to commute to the hospital back and forth, and to eat, and at least have that basic maintenance of life expenses. Those are such serious and severe issues that almost 60-70% of our patients, even if we provide them free dialysis, would give up and quit, and they'll just take their child home.
So would you say, as Dr. Priya did, that they essentially disappear, as this particular child did for a few years before coming back? Is that your experience from what I understand you see here? That the families just leave, Dr. Ali, never come back?
I think
Does
that
that
would be common for my setting
Yeah.
too. That it's not that they announce that they will stop treatment. I work in a private setting, so oftentimes the patients that we follow are those that agree to start, and they do begin. And I have to say that I don't think we have actually advised anyone against dialysis, because we feel that it's if the family would like to begin, that is something that they decide is in the best interest of their patient. But I did notice that a lot of families were disappearing. So actually measured it, and it turned out that it was very concerning 50% of kidney failure patients who disappeared. And by disappeared, we know, either confirmed or, from the medical records or from on the phone of the family, that they died at home. So that's essentially what happens to these patients.
So this unfortunate thing is I think the way how they justify this decision a lot of times is that they then try to place their blame and share that burden with the hospital or doctors, or find out, that with their treatment, with your treatment, he was still not getting better and he was still very sick. So that's why we took him. Or sometimes they would say that, we took him to a traditional healer, or, and then he offered a better treatment which we could afford or something. So a lot of times we get the blame of not doing the right thing for the patient, and so they didn't, since he was not getting better, they just left. And I'm happy to get that burden, that blame. Do you feel the same?
I know that. So there's definitely an element of denial in the diagnosis. And I think without verbalizing it, our patients don't necessarily say it, but they're hoping somehow that this disease will get cured. And so, yes, they do sometimes disappear to seek other forms of treatment. But there is a significant element who don't blame us. They finally accept the diagnosis, but they start reducing. They'll reduce the number of sessions of dialysis, or they'll skip days of PD. And so the complications and the morbidity build. And what we see then is that they get sicker, they have more hospital admissions. And so, in effect, their expenses actually are more than if they would have done dialysis in the way that was prescribed. And so this sort of vicious cycle of costs, non-adherence, and more cost building because of it is something that really can drive families into poverty.
We have some participants from Southeast Asia, Malaysia, and many of the participants I see in the list are from Middle East. So do any of the participants want to share experience from their context, how different contexts of different parts of Asia would change things for them? And Dr. Aaron is also raising his hand to add some comments. I can see.
Although I don't practice in Asia, and I'm sorry I couldn't find the button for the picture. I just wanted to recognize, acknowledging Dr. Pais's work in catastrophic healthcare expenses related to dialysis, and Dr. Lanewala's work related to indirect expenses of dialysis, that the impacts of the treatment of kidney failure on patients, but also families, as we mentioned, the parents and siblings, are felt worldwide. Alison Jor from Sydney, in a review on this, described a child needing dialysis as a tragedy for the child, their family, and their community, and she's right. We studied this in the US at a few different centers of doing qualitative studies, and what was particularly interesting for me in doing that work, first, it was quite eye-opening because I didn't appreciate the degree of indirect costs and burdens that my patients' families and particularly their siblings were experiencing. But what they described was not to the same degree, but that their entire lives had been put on hold and impacted by this disease and its necessary treatments, and that those themes, although they don't reach necessarily the same extremes, I move patients thousands of miles so that they can get dialysis treatment, and have done, and uprooted families and in some ways destroyed families from doing that. But the themes seem to be universal, and we reviewed that a couple of years ago, and found while they can occur to different degrees, these same tensions exist with pediatric dialysis, for better or worse, everywhere globally.
I think one question that always comes to my mind is how much to reveal to the parent in advance of what they're going to face. We know what's coming. At the same time, I don't know if I tell them that, look, this is what's going to happen next and how much difficulty you're going to face. It may be that it would make them stronger and more prepared to deal with it. Maybe they would actually be more proactive in mobilizing resources, or it may scare them away and refuse to start dialysis for the child. And my fear is that if they do that, then my patient would lose whatever chance they had at living.
May I ask this question from one of our faculty members here in pediatric nephrology? Do you feel heavy conscience when you're counseling a child that he needs a dialysis, maintenance dialysis, and you know very well that it will not be, the family will not be able to bring this child? Do you feel that burden on yourself? How can you explain? How do you sleep at night?
Yes, I do feel burdenized. But having said that, we have to give them the options, that this is the available options that we have. We cannot force them to comply to that, but yes, we can make slightly, maybe we can make things better for them, that if give them a hope that if they can pursue the treatment, it will give some better days to the child. Regarding sleeping well at night, some nights are good again and some nights are bad.
So we feel good about what we can do if allowed, but at times it's very depressing that, you know, the family can still not take it. So like we mentioned, other participants from other part of the world, I've been to Malaysia. I think Malaysia is more of like a high income country with all kind of resources. Do you feel, do you see anything similar to this, that a patient, you cannot offer them life-saving treatment and just because they're too far away to get it?
So while we're waiting there, I think Dr. Priya's question, as I heard it, was very interesting. And I feel that's a contextual thing. If I understood you correctly, how much information do you provide? I think that's what you were talking about. at one time when you know you're talking to parents and it's a child who's obviously got a pretty nasty future ahead. Contextually, it would be interesting. I suspect in Pakistan, for example, unlike United States, unlike Washington, I think physicians hedge a great deal in providing full information. I don't know what your experience is. Where when I was in the States, you had to put everything out there at the first time, make them understand it. Do you ever find yourself, in order so that they do not lose hope, try to find the balance so that you hedge on how much information you give to the parents when you first see the child? Dr. Priya, I'm just curious.
So I think the medical information we give completely in terms of the diagnosis, the treatments that are there, and we are very clear that if dialysis is not provided, what the outcome would be. The challenge comes in the picture you paint of what might happen in the non-medical challenges. It's not information in the sense that every family situation, like you said, every family situation will be different. But we can sometimes anticipate looking at the socioeconomic background of the family, that these are families who are very likely going to face a lot of financial difficulty. So should we describe how difficult it's going to be? At the same time, from my experience, the families that move ahead with treatment and who actually reach transplant, it doesn't depend on their finances. This is subjective. It appears to actually be those who are determined to do it. And so these families somehow manage to raise funds. We work with families very actively to raise funds as well. And so if we had painted that bleak picture that, this is how much it's going to burden you in terms of finances. Of course, there are a lot of other burdens that, as Aaron described, that are felt worldwide. But if we were just really paint a negative picture, which may be true, a negative picture in advance, a determined family who might otherwise have reached transplant may choose to give up on treatment. And so I would say that our group does not actually paint such a negative picture. Instead, we begin and see how it goes. And yes, it is a lot of suffering that does happen, but at the same time, the pediatric nephrology team here was saying, you do feel that the parents feel that they are doing the best for their child. And if they had never tried, they might never have had that experience of giving it their best. If they gave it their best and despite everything couldn't continue, at least they will be left with that feeling that they tried. Of course, if the outcome is poor, they're going to be left with a lot of other pain as well. But yes, so a lot of medical information, not too much of negative painting.
Okay, I just wanted to make a comment before we move on to your final case. It was, I think, the moral burden that the physician over here seems to be carrying is significantly greater. It's not just limited to the medical consequences of the disease and the treatment, but also the social and the economic consequences of the whole situation. So your perspective and the cross that you bear in Pakistan and I think in India and perhaps South Africa is significantly more, although South Africa is better as far as economics is concerned. However, so in the low middle income countries, the low income countries, that is a moral pressure that our medical training does not prepare us for. That contemporary bioethics or any degree in that does not prepare you for. This is something that you learn in the trenches when you face your patients and when you have sleepless nights. So that I think there is a major difference that I'm seeing in these. This is my perception. So I think we should move on to the next, unless you have a question. You have, okay, one question? Yeah.
Okay.
Assalamu alaikum, adab. I am Tasneem and I am a student of comparative humanities at Habib University. So I'm not a physician, and I just wanted to add one thing um, in the context of what you said, Dr. Priya. I don't think that hope is such a fragile thing. I don't think it's something that can be destroyed that easily, and it's definitely not something that someone can instill in someone else or someone can bring about in any certain way. It's something that is quite inherent to the human condition, and um, it I don't think it's something that can be lost entirely. When a parent makes a decision to let their child die, then it's a terrifying decision for anyone to make, let alone a parent. And in that context, I think that even just taking the child back home, they would make sure that their child dies in peace. And they still, no matter how many children they have, no matter what context they live in, they still acknowledge and understand that their life does not begin and end at death, right? And I don't know if that made sense, but my point is just this, that if there is a certain context in which you maybe as physicians, if you try to control the amount of information that you give with the under the impression that you can influence their decision um completely, like, of course, as physicians you have the most say, especially in Pakistan, where your opinion matters sometimes more than the families and the head of the families. um Regardless, I don't think that withholding information can influence that decision, because to a great extent that decision has already been made. They know their child is sick. They know that they will have to face some costs. They know that they're already sacrificing a lot to be there. And they understand, I think, to a great deal, that to a great extent, that there are some things that they will have to compromise, and a lot will go wrong. So I think that giving them that information will just clarify their decision for them instead of making it.
I
Yeah,
agree
thank
with you. I am definitely not advocating for withholding information. But information is often factual. So in terms of, this is the treatment your child needs, this is the diagnosis that they have, this is how much it's going to cost you, all that is very clearly laid out. And I agree with you completely that the family is quite capable of making their decisions depending on their own factors. It need not be based entirely on what the medical team says. And I'm quite surprised. We may think that we play the biggest role in their decision making, but they have their own ways of making decisions. Oftentimes, I'm sure it's similar to you all. It's the elders in the family, people we don't see, who make the decision for them. In terms of what I was talking about was actually trying to describe a possible burden that may come. So, given that these burdens may be so high, was really what I was trying to say. But otherwise, full information is indeed ethically correct to give. And when we did a qualitative study of our caregivers, and when we were looking at their sources of coping, because our families basically are joyful, the ones who we see. And we were asking them, how do you cope? And there were so many different sources. Some said religion, prayer. Some, in fact, were completely turned away from religion. It's very interesting because they were angry at what had happened to them. We found parents who had good spousal support, especially the mothers, because as you know, the mothers do the majority of caregiving. If their husband was supportive, that was a huge source for them to cope. And the mothers who were being blamed by the in-laws and the fathers and the father himself for the child's disease, they found it much more difficult to cope and continue to have hope. But even they ended up taking, joy from just their child, however ill they were. I remember one mother telling me very clearly that just seeing her child smile, she didn't care about anything else, all the difficulties that she had to go through. So yes, I agree that, parents are very resilient for the most part, and continue to have hope.
Okay. So I think we can now move on to the third case. Yeah. Now, this third case, I will present it. It's about a setup like it's from the SIUT setup where all the treatment for everyone is completely free of cost. And it's about, I mean, all of us who are working here are familiar with similar scenarios. This is a hypothetical one in which, a girl, say about 10 years old, comes to us and requires dialysis, and we have initiated dialysis, and since they are also like from a place from where commute to the dialysis center twice or thrice a week is very, very difficult. So the best quality of life, best treatment in terms of quality of life and for the survival of this child would be a live-related transplant. And we do only an ABO compatible transplants, means that you have to have a certain blood group to become a donor. And in this family, it's a big family of 10 people, 5 other siblings, a father who is a manual laborer on daily wages, and he is the sole breadwinner for 5 other children, his wife, his elderly parents, and a sister who is unmarried, also lives with them and is completely dependent on this family, on his brother, for all her financial and other rest of the daily living. And now, when we evaluated them for transplant, there are only 2 eligible donors. One is the father who has this blood group, and this paternal aunt of the child who is willing to give her kidney. She says explicitly that I have raised this child, I feel her as of my own, and since she's an adult and she wants to donate kidney, and the family also wants her to be the donor, because they say that the father, he is the sole breadwinner, and if anything goes wrong to him or if he falls sick after this surgery, then who will feed this family? And they want this lady to become a donor. So when we see this in our context, we know from experience that the consequence of organ donation in a young unmarried lady can be very devastating in terms of that, arranged marriages, they do not get a suitable match. They don't get married. Because anyone who would find out that, oh, she has only one kidney, she has donated, so they will move on. She will not get married. And also, since she's all financially dependent on that family, so if she does not, if she herself would come up and say that I don't want to be a donor, then it would be very difficult for her to stay and live in that family, And so by all definitions, such ladies in our culture and in our society are vulnerable. They can be made to sacrifice for the whole family and for the good of the whole family. and they can stay unmarried and live in that home and be that donor. So we as physicians, and there is another point in this context, is that even if she gets married, um, she has a whole life ahead of her. We have data, medical data statistically, that young donors are at a higher risk of getting complications from kidney donation later in the life, like 20, 30 years from now. And also that when she gets married and becomes pregnant, for her every pregnancy, she would be at a much higher risk as compared to other people. So all her pregnancies would be high risk, her whole life will be at higher risk, and the other point is about the institutes like us that are funded by public funds. And what we think is that we owe this to the society, that the responsibility is ours to ensure that the whole family as a unit, we do good to them rather than individuals, So if this otherwise healthy lady who potentially has a whole healthier life ahead, we we take her as a donor, and what if that the child who has been transplanted goes back on dialysis after 10, 12 years, and this lady also is at a higher risk and becomes, let's say, a kidney failure patient later on. So we, in our situation, would not have done good to the society overall in the long term in using those public funds. So we think that in this context, it is our responsibility to say no, even if they are, they've come up and she's willing to give the consent and she wants to donate, we will say no to this lady, that no, we will not take you as a donor. Okay, so maybe we can, so the conflicting values here are this, that you're refusing the person's right to choose in their by using the authority of that physician, that paternalistic attitude by the physician, and you're compromising the autonomy.
So, Dr. Lee, that's an interesting case. So I would look at it from this point of view as to who is your primary responsibility at this point? The person whom you're treating, who's come to you, or the entire neighborhood and the society, and the person who the donor, potential donor may sometime at one point get married to.
Yes.
So you have to think of that. So you you may be able to actually do good. The transplant may work for the next 30 years. The recipient and the donor may be fine forever. I mean, for natural lives. So that could be also an outcome. Why would you think of your transplant failing and your donor also having chronic renal failure? So my question is that do what you can. You can help this person. This is an adult who's come to you and says that she is willing to donate. Why do you suddenly have to become the messiah of the entire community and say, no, no, I have to look beyond and see this and that? You don't have that kind of time. Just do what you can then and move on to the next patient.
And sleep well. Sleep well. So yes, that is the dilemma here. That who does the physician, who's the primary responsibility of the physician? Is it towards that individual patient that you're treating, or on a bigger scale, if you want to treat that whole family, versus, like you said, it's the whole someone unrelated to that family and goes to that society. So, Lakmal.
Yeah, so I would, in addition to what Dr. Amir has said, I would raise a different point of view, and this is based on interviews, etc., with women. I think SIUT does a good job in the sense that it is protective towards women. I think what SIUT needs to do is not to go overboard in this and think that unmarried women within families have no agency at all. Because I think that is not a good thing to do, because there are enough women for this particular woman, and I can think of one an actual case that I had written up about a single woman, something very similar. Large family, one breadwinner who needed the kidney. And she was a sister, wanted to give the kidney. And it took her a while. She had a lot of agency. And again, the physicians didn't want it. And the family, again, this whole issue of what will happen, she won't get married. For women, there is a life that does not always have to have marriage. What this particular woman, and that's a social thing that we are very embedded in, but it's changing in Pakistan. This particular woman did convince the physicians, fortunately, and to give her kidney, and she did so also by involving the rest of the family. And following the transplant, in one of her interviews with her, what she said was that, I live in a joint family, and as a single woman, and I was not making money, I had no importance in the family. However, once I gave my kidney to my brother, whom I love, my position in this particular family has risen tremendously. So the wives of my brothers who would pay me no heed, now whenever they go shopping, they say, Azra, why don't you come with us, etc. So I think it is important. Women are oppressed in our society, but we must understand women do have agency. And so it is important, therefore, to not make it a blanket thing that we will not take kidneys from single women, because I think that does, in some cases, would do disservice to that woman who has thought it through and knows her interest better than you know her interest.
Well, another point that was in my mind to discuss with Aaron was that considering that harm principle and considering that whole societal, how would you approach a problem like this at your end? Would you knowingly take this lady's kidney in your setup?
I should hope so, Aaron.
Well, with that framing, yeah, so kind of three quick thoughts. First, our setup is just a bit different in the sense that our living donors are evaluated separately. I don't participate in that evaluation, nor do any of my colleagues. That's done actually at the adult hospital to try and separate things. That being said, we're the ones who introduce living donation, and we're the ones who tell parents that they should do it. And I certainly have encouraged young mothers who are at the exact same age to be living donors. I've discussed with them the risks of it, as Dr. Lanewala described, and tried to support them in making an informed decision about what they want to do in those circumstances. So I think both we want to be thoughtful about the vulnerability of anyone who's choosing to undergo a surgery to benefit someone else and to take on a chronic disease to benefit someone else, and also recognize the value in what they're choosing, and recognize that sometimes the reasons aren't as good as even kind of what's been described, in the sense that there's a famous study at the University of Wisconsin in transplant where psychiatrists met with living donors to try and understand why they did it, and they made the decision immediately. The folks, Fellner was it was Fellner and Fellner. They made the decision immediately upon hearing it, before hearing any risks, benefits, or anything else. And they went on to donate, and nothing they heard changed things one way or the other. And it was a good thing that they donated.
Yes.
So there is an element for altruistic donation. We don't see that here. We are not legally allowed in Pakistan to do that. But in US, for example, you can donate without an identified recipient, without being their relative or by any association whatsoever. I know a person who donated her kidney and then her liver, a portion of her liver, in a couple of years. And actually, we actually sat as a faculty and discussed if she would need some kind of psychiatric evaluation just to make sure that she's clear on that account what she's doing, because obviously it carries its risks. But again, a person donating. But sometimes that's what I feel. We as doctors, this is the second kind of paternalism that we practice. Sometimes, so this is the reverse of autonomy, that we still try to instill our context on the donors, for example. We would still try to fix them up in the way we think is appropriate. So how can we, be planning for their life? How can we be deciding that she needs to get married in 30 and have to live through in the next 30, 40 years, and the way she would for any person, for a male or female. So this is again. So it actually, if you even if you're looking in our context, in the dependencies context, transplant probably provides the best solution that takes care of most problems and would provide a reasonable life to that recipient, and would be the best outcome for the family in terms of resource required, in terms of long term. So yeah, it's really so the most of the time these donors are invested for their relationship with the recipient. And this kind of yes, we should make formally assess that this is not duress, this is not some kind of payback or something that I think is required on part of as being donor advocates. We should be making sure that this is not but we should not take it beyond a certain point, as Dr. Mozam made a point of telling us, right? We should not just keep doing that.
We have some important questions and comments online. So just keep it there. So we have some questions from Dr. Valerie, and she wonders what the family would do if the aunt was declined. Would they feel resentful? And if there are some risks which also apply to brother, father, mean that father cannot work or support the family. So would you consider those risks in your evaluation? Dr. Ali?
Well, yes, definitely. I mean, these decisions are the toughest ones, and that's why it's not taken by an individual, it's by the team, and the team with different specialities. There are social workers, a psychiatrist, and the whole transplant team takes such decision after knowing the whole family. Like we said, as a general rule, we try to discourage such donations, but in special cases, yes, we may we take it. And
can I make a comment?
Yeah.
Dr. Valerie, if the part of the assessment is to ensure that that woman is not saying, take my kidney from duress, and that is important. If that is so, you do not take that kidney. But the point I think that we've been making here is that needs to be assessed. The fact that somebody is a single woman should not be by default a no to taking the kidney from her. But certainly, one has to be very careful within our context that you assess that there is no duress, and this is done here, at least during the time when I was involved, by speaking to her separately, etc. But under duress, no, it doesn't. You don't take the kidney.
So we have two comments.
Yeah.
Tasneem and Swalia.
And actually, mine is actually connected to Dr. Mazum's point, because I think that one of the things in this situation is that, in fact, SIUT actually tries to protect the women in the sense that if she is under duress, then they will take it upon themselves, the medical team, so that she's not, so that the family does not know that it was actually her refusal, that she refused herself, but they'll take it upon themselves. So I think where different situations would call for different things.
I have a follow-up question connected to both of those things. Is it something, I don't know if you would call it ethical or not, but is it something that's possible to do to make up a law or something to convince the family that actually this is not even a possibility, so that the woman, hypothetically, if she is under duress, she doesn't come under like fire by any of the family members? Is that something that is possible, that the medical team would take it upon themselves and maybe upon the state, or make it some external situation where she actually isn't allowed?
So what you're saying is whether the medical team would lie.
Yes.
And
To protect the
woman. Yeah, but
But here, I think Priya has mentioned that in India it's not allowed. It's only parents or grandparents can give their kidney to their children.
But she has another solution as well, that
So we actually, all kinds of stuff goes on, in the sense that, yes, legally only a parent or grandparent can give, but we, this is where I see where Dr. Ali's concern is coming from, not from the point of view of marriage or childbearing, but we openly will get comments that, yes, I'll get someone, my mother, grandmother, aunt, to donate. And I just wanted to ask, the question is that, would it not be better for us to address the duress of the person who is, or the family members who are trying to put pressure on the woman? Because my feeling is that if we make up laws or try and protect by hiding the fact that putting pressure on a woman to donate is wrong, what will change?
Tough one to answer. I don't know. But in the interest of time, we have Hala Al-Hali.
Can I, Dr. Ali, with your permission, just very quickly, in answer to what you said, one could make such a law in Pakistan, but the law means nothing because the decision is going to be made in that clinic. So I would be very pessimistic. We have a lot of laws, even the law we have now for organ transplantation. People try to get around it. I think it's the physicians and their involvement and their recognition of you cannot force anybody to give a kidney. So that would be my response. Sorry, Dr. Ali, go ahead.
Yes.
You had another question.
Hala Al-Alam from Saudi Arabia wants to share her experience.
Yes, good morning, good afternoon. I'm Dr. Hala Al-Alam, pediatric intensive.
Can you keep your microphone a little bit closer? Your voice is very extremely low.
Okay. This is Dr. Hala Al-Alam. I'm a pediatric intensive and bioethics working in Riyadh, Saudi Arabia.
Dr. Hala, we are unable to hear your voice because it is extremely low. Can you write if it is possible?
Is it better now?
Yeah, it is audible now.
Okay, so I'm a pediatric intensivist who work with post-transplant kidney, liver, and other organs. And we have the practice here to transplant kidneys from cadaver to living related and living non-related. And actually, the nephrologist and also the transplant surgeon found it challenging when a person from the family wanted to donate initially with an emotion and so on, and then worked all the work, blood work, and the preparation were toward suitable organ donor, and then later on with assessment by psychiatry, psychology, and on multiple sessions, they may feel some hesitation after they know certain facts about living with one kidney. So the team themselves, the committee, would tell the family or would tell the patient that we are not pursuing the procedure because something is not suitable to continue. So we take it on our shoulder to decline a suitable or living related or non-related organ donor in order not to have the coercion or the being under pressure or under emotion donating part of their body. Thank you.
Thank you very much. I think
Yeah, that makes a lot of sense, because particularly within joint families, if you think a particular, and this was your question, if a particular person does not want to donate and is under duress, and this is my opinion, but this is also called gatekeeping. If you look at Jim Childress and Tom Beecham's book, they call that. In that particular case, saying that we've tested, but things are not suitable, etc., in order to protect that person, I would consider it ethical.
very good. So all these topics are, are such that we wish to have more time to discuss all of them, but we have already overshot our allotted time. I really want to thank everyone who participated in these discussions, especially Aaron and Priya, who took out time from their busy schedule. And Aaron, for him, it's 5 in the morning right now, and I see him still fresh. I envy you, my friend. But thank you very much, and we hope we can continue such academic exercises in future also.
And Dr. Ali, I think the merit of this particular forum was that we heard different points of views. And this is something I think all of us, I know if Dr. Valerie is still on, this is an area of our interest, that in bioethics, we need to hear different voices around the same table. So I think, yes, this worked well.
Thank you very much again. Goodbye.
Thank you. Thank you, buddy.